Welcome to the funnel effect.
Glad to be here for this one.
Yeah, today we are digging into something that is honestly going to change your next doctor's visit. We are looking at the 2026 Echo Ekivi Prep Picpomata Exifesa PC NLEP CNA guideline on the management of dyslipidemia.
That is quite the acronym soup right there.
It really is. But, I mean, it's important to state exactly what this is. It's a massive report by the American College of Cardiology and the American Heart Association Joint Committee.
Right.
And it was chaired by Dr. Roger S. Blumenthal and vice-chaired by Dr. Pamela B. Morris. Plus, it was developed in collaboration with, like, a dozen other major medical organizations.
It's basically the who's who of cardiology right now.
Exactly. And our mission for this deep dive is to take this absolute brick of a clinical document and decode it for you. We want to turn this highly technical stuff into practical, actionable knowledge. Because this is a massive shift in how the medical world looks at cholesterol, triglycerides, and heart disease risk.
It really is a structural pivot. Because, heart disease doesn't just happen overnight. It's not like catching a cold.
Right, it's a slow burn.
Exactly. Atherosclerosis is cumulative.
Yeah.
It builds up over decades. And what this document really hammers home is that we have to look at your lifetime exposure to bad cholesterol.
Which means the choices you make today actually matter.
Oh, absolutely. The numbers you track today, the choices you make right now, they literally dictate your heart's future decades from now. It's all about catching the risk early and keeping those lipid levels optimal over the long haul.
But to do that, we can't treat what we don't accurately measure. And the source explicitly states that the old ways of looking at a standard lipid panel are officially outdated.
Yeah, the math is essentially getting retired.
Which is wild to think about. Like, the formula my doctor has been using for my whole life is just getting tossed.
Pretty much. For decades, LDL, the bad cholesterol, was estimated using something called the Friedewald equation.
The Friedewald equation. Okay.
Right. It was developed back in the 70s. And it basically takes your total cholesterol, subtracts your HDL, and then subtracts your triglycerides divided by 5.
Divided by 5, so there's a fixed ratio in there.
Exactly. It assumes a completely static ratio of triglycerides to VLDL, which is very low-density lipoprotein.
But, human biology is almost never perfectly static, right?
No, of course not. That fixed divided by 5 part completely breaks down under certain conditions.
Yeah.
Like if you have high triglycerides or if your LDL is actually being pushed really low by modern drugs.
It just skews the result.
Severe underestimation. You might look perfectly fine on paper, but your actual plaque-causing burden is still dangerously high.
That's terrifying. So what's the new math?
The 2026 guidelines are pushing doctors to use the Martin-Hopkins or the Sampson-NIH equations instead.
Okay, so how are those better?
Well, the Martin-Hopkins one, for instance, gets rid of that fixed denominator of 5. It uses an adjustable factor that's tailored to your specific non-HDL and triglyceride levels.
So it adapts to the actual person.
Exactly. It's just way more accurate, especially when your LDL is on the lower end, which is exactly when you need precision to make treatment decisions.
Okay, so step 1, fix the math. But the guidelines also say we need to stop just looking at the total weight of the cholesterol. They are really pushing this thing called ApoB. What is that?
ApoB stands for apolipoprotein B. And this is a big deal. See, measuring LDL-C just gives us the total mass of the cholesterol inside the particles.
It's just weighing the cargo.
Right. It doesn't tell you how many actual trucks are on the highway carrying that cargo. ApoB is a protein tag. There is exactly one ApoB molecule on every single plaque-causing particle in your blood.
Oh, wow. So if you count the APO.
You get a direct one-to-one count of the exact number of atherogenic particles. It is just a much better indicator of actual risk.
Because you could have a normal total weight, but it's packed into thousands of tiny, dense particles that can easily smash into your artery walls, right?
Precisely. We call that discordance. Your LDL weight looks fine, but your particle count, your ApoB, is through the roof.
Man, that's why the old panels miss so much. Now here's where it gets really interesting. The guidelines talk about this genetic wildcard, lipoprotein, or LPA.
Yeah, LPA is fascinating and incredibly dangerous.
Break that down for me. What makes it different from standard LDL?
So, mechanically, imagine a standard LDL particle is like a tennis ball floating through your bloodstream. It might bump into things, but it keeps moving.
Okay, I'm visualizing a tennis ball.
LPA is that same tennis ball, but it's wrapped in barbed wire.
Yikes. That paints a picture.
That barbed wire is an extra protein attached to it called apolipoprotein. It has these sticky structures, kringle repeats, that make it hyper-prone to getting stuck in the artery wall.
So it just digs in and builds plaque way faster.
Yes, and worse, it actually mimics a protein in your body that dissolves blood clots.
Yeah.
So it competes with it, meaning your body has a harder time breaking down clots, while this particle is actively causing inflammation.
That is a terrible combination. And looking at the numbers from the source, if your LPA is around 50 milligrams per deciliter or about 125 nanomoles per liter, your risk of a cardiovascular event goes up by 40%.
It's a huge jump.
And if it hits 180 milligrams per deciliter, the risk is 4 times higher. That's like having a severe genetic high cholesterol condition.
Exactly. And the most critical thing you need to know about LPA is that it is almost entirely dictated by your DNA.
Really? So eating better won't fix it?
No. Diet, exercise, even standard statins, they barely touch your LPA levels. It's a genetic fingerprint.
So if it doesn't change, that means you only really need to test it once, right?
That is exactly what the new guidelines state. You only need to measure it once in your adult life to know your baseline risk.
Wow. So if you are listening to this and you've never had your LPA checked, this is the exact test you need to ask your doctor about at your next physical.
Absolutely. It's a class 1 recommendation now.
Okay, so we've got the accurate data now. Better LDL math, ApoB particle counts, the LPA baseline. What does a doctor actually do with all this?
They run it through the new playbook. The guidelines call it the CPR framework.
CPR. I'm assuming that doesn't mean chest compressions in this context.
No. It stands for Calculate, Personalize, and Reclassify.
Let's start with the C, calculate.
Right, so we are shifting from the old calculators. We used to use the pooled cohort equations, the PCE. Now we use the Prevent SSCVD equations.
What was wrong with the old PCE calculator?
It was built on really old data, like late 20th century populations. People smoke less now. Baseline health is different. The new Prevent equations use modern, diverse data. They also factor in kidney health and completely remove race as a biological variable.
Okay, but wait. The source says the new Prevent equations give risk estimates that are 40% to 50% lower than the old calculator. If the numbers are lower, aren't we going to miss people who need treatment?
That is the exact pushback a lot of people had initially. But here's the thing. The old calculator was overestimating risk. It was a blunt instrument.
So Prevent is just more accurate.
Exactly. It naturally reads lower because it's calibrated correctly to today's population. But to make sure nobody falls through the cracks, the guidelines actually lower the threshold for treatment.
Ah, I see.
Yeah, so now if your 10-year risk is just 3% to 5%, that puts you in a borderline category where statins can be considered.
So the gauge is more precise, and they just adjusted the red line to match.
Spot on.
That brings us to the P in CPR, personalized.
Right. This is where we look at risk enhancers, things the calculator might not fully capture.
Like family history.
Family history, chronic inflammation, sure. But the biggest update here is a massive advancement in women's health. The guidelines now officially recognize reproductive risk markers.
That's huge. What exactly does that include?
If a woman has a history of early menopause, meaning before age 45, or complications like preeclampsia or gestational diabetes, her cardiovascular risk is inherently higher.
Wait, how does a pregnancy complication translate into a heart attack 30 years later?
Think of pregnancy as an extreme 9-month physiological stress test on the vascular system.
Okay, that makes sense. A lot of extra blood volume.
Exactly. Massive changes in blood volume, cardiac output, insulin resistance. If the blood vessels fail that stress test, which shows up as preeclampsia, it unmasks an underlying weakness.
So the pregnancy didn't cause the heart disease. It just revealed that the plumbing was already vulnerable.
Exactly. And now doctors are explicitly instructed to factor that history into treatment decisions today.
That is amazing. Okay, so we've calculated, we've personalized. What if the doctor and the patient are still on the fence? Like nobody wants to start a daily pill if they don't have to.
That is where the R comes in, reclassify.
And how do we do that?
We use a coronary artery calcium score or a CAT scan. It's a quick CT scan of the heart that specifically looks for calcified plaque in the arteries.
Now, calcium means it's hardened, right? Like bone. I thought the dangerous plaques were the soft, squishy ones that rupture.
You're right. The soft plaques are the ones that typically rupture and cause a heart attack. But calcification is the late-stage healing response to plaque buildup.
Oh, so if there's calcium, it means there's a lot of the soft stuff, too.
Exactly. It's a highly reliable surrogate marker. If we see extensive calcium, we know the disease process is highly active throughout the arteries. We measure it in something called Agatston units, or AU.
Let me make sure I'm getting this. It's kind of like The risk calculators are like checking your neighborhood's crime rate to see if you need a security system. But the hack scan is like looking directly at your front door to see if someone has already tried to pick the lock.
That is a perfect analogy. You are looking directly at the actual disease, not just estimating the probability of it.
So what do the scores mean? If I get a scan, what am I looking for?
Well, if your CAC score is exactly 0,
0. Nothing there.
right, you have no calcified plaque. In most cases, you can safely defer statins for 3 to 7 years and just focus on your lifestyle.
That's great peace of mind. What if it's not 0?
If it's between 1 and 99, you have mild plaque. The recommendation is to start a moderate intensity statin to stop it from getting worse.
Okay, and higher.
If it's over 100 or above the 75th percentile for your age and sex, you need aggressive therapy. The goal is to drop your LDL by at least 50%. And if it's over 1,000,
Over 1,000, wow.
yeah, that indicates severe, diffuse disease. You need intense multi-drug therapy immediately.
There's also a really interesting rule change about how we find this calcium. The source talks about incidental findings.
Yes, this is a very practical update.
Basically, if you go in for a CT scan for something totally unrelated, say checking your lungs or looking at a stomach issue, and the radiologist happens to see calcium on your heart arteries in the background,
The doctor is now instructed to act on that immediately.
just skip the dedicated CAC scan and get straight to treatment.
Exactly. It uses data we already have to save lives.
I love that. All right, before anyone reaches for a prescription pad, the guidelines are very loud about the foundation of all this. Lifestyle.
Always the first step.
But the 2026 guidelines get incredibly specific. They endorse the AHA's Life's Essential 8 and push for plant-based, Mediterranean, or DAS diets. And they heavily recommend working with a registered dietitian nutritionist.
A dedicated RDN can make a massive difference.
But here is where I have a question. Let's unpack this. The supplement industry is worth billions of dollars. People take fish oil, red yeast rice, garlic extract. Yet these new guidelines give a strict Class 3 no-benefit recommendation against using dietary supplements to lower LDL. Why the ban?
What's fascinating here is the difference between moving a number on a blood test and actually stopping a heart attack.
Okay, explain that, because red yeast rice does lower cholesterol, right?
It does. Red yeast rice contains a compound called monocolin K, which is literally identical to the active ingredient in the statin drug lovastatin.
So it's basically a natural statin.
Exactly. But as an unregulated supplement, you have no idea what dose you're actually getting from batch to batch.
So it's inconsistent.
Highly inconsistent. And more importantly, the guideline committees look at hard clinical endpoints.
Yeah.
There is limited to 0 high-quality evidence that taking these supplements actually prevents heart attacks or strokes.
And that's the whole point of treatment.
Right. Relying on an unregulated supplement gives people a false sense of security, and it often delays them from starting proven life-saving medications.
Okay, that makes total sense. They also issue a pretty severe warning about extreme simple carbohydrate restriction, like the keto diet.
Yes. The mechanism there is something doctors are seeing a lot of. When people go on extreme low-carb, high-fat diets, they drastically increase their saturated fat intake.
Because they're eating lots of butter, bacon, heavy cream.
Right. And in a lot of people, that massive influx of saturated fat causes the liver to literally downregulate its LDL receptors.
Wait, meaning the liver just pulls the receptors inside?
Exactly. It just stops clearing cholesterol from the bloodstream. Yeah. So the patient might lose weight and feel great, but their LDL and ApoB absolutely skyrocket.
That is a dangerous hidden side effect. And speaking of extreme dietary rules, if someone has triglycerides over 1,000 milligrams per deciliter, the guidelines drop the hammer.
Absolute zero tolerance at that level.
Eliminate all added sugars and completely abstain from alcohol. Why such a harsh rule right at that 1,000 mark?
Because at 1,000 milli-GDL, you aren't just worried about a heart attack down the road, you are at immediate risk of acute pancreatitis.
Oh, wow. Why the pancreas?
Triglycerides are carried in these massive particles called chylomicrons. When levels cross 1,000, your blood literally becomes viscous, it gets thick, and those giant particles physically clog up the tiny blood vessels inside the pancreas.
That sounds incredibly painful.
It is localized ischemia and massive inflammation. It can be fatal.
Yeah.
And alcohol and refined sugars are rocket fuel for triglyceride production. Having a drink when you are at 1,000 isn't a long-term risk. It could put you in the hospital with pancreatitis by tomorrow.
Okay, message received, no alcohol. So let's say a patient has their diet dialed in, but their genetics are just working against them. The numbers are still bad. We have to move to the pharmacological arsenal.
The toolkit has grown a lot since the older guidelines.
Statins are still the champions, right? The first-line therapy.
Undisputed first line. They block cholesterol synthesis in the liver, which forces the liver to pull more LDL out of the blood. Plus, they directly calm down inflammation inside the artery walls.
But what if a high-dose statin isn't enough?
The first add-on is a drug called ezetimibe.
How does that work?
Statins block your body from making cholesterol. Ezetimibe works in your gut to block your body from absorbing cholesterol from your food.
Oh, that's a great 1-2 punch.
It is highly synergistic.
And if we need the heavy hitters, the source talks about PCSK9 monoclonal antibodies, alirocumab and evolocumab.
These are incredible drugs.
Yeah.
So your liver has these LDL receptors that clear cholesterol, but your body also produces a protein called PCSK9, which actually destroys those clearing receptors.
Why would the body destroy its own cleanup crew?
It's an evolutionary feedback loop that just works against us in modern times. So these new injectable drugs bind to that PCSK9 protein and neutralize it.
So the cleanup crew survives.
Exactly. The liver gets covered in active receptors, and your LDL levels just plummet, like an extra 50% drop on top of what a statin does.
That is amazing. Now let's address the elephant in the room with statins. Muscle pain?
Statin-attributed muscle symptoms, yes.
I mean, so many people are terrified to take statins because they've heard it causes horrible myalgia.
And the guidelines spend a lot of time on this. Here is the reality. True muscle damage from statins is exceedingly rare. In blinded trials, the vast majority of muscle pain is actually a nocebo effect.
Meaning they expect it to hurt because they read it on the internet, so their brain actually creates the pain?
Precisely. The pain they feel is real, but the cause is psychological, not the drug. So doctors are instructed to test the patient's creatine kinase, or CK, levels.
What does that tell them?
If CK is normal, the muscle tissue is not breaking down. It's structurally fine.
So the doctor shouldn't just give up on the statin right away?
Never. They'll lower the dose, try a different statin, maybe do every other day dosing. The heart-saving benefits are just too massive to walk away from without trying everything.
Oh, what if they truly, absolutely cannot tolerate a statin? The guidelines have a new option now. Bempedoic acid.
Yes, based on the CLEAR Outcomes trial. It's a fantastic alternative for statin intolerance.
The source says it gives about a 20% LDL drop. But why doesn't it cause muscle pain like statins sometimes do?
It's a really clever mechanism. Bempedoic acid is a prodrug. It doesn't actually work until a specific enzyme in the body activates it.
Okay.
And that specific activating enzyme is only found in the liver. It does not exist in skeletal muscle tissue.
Oh, wow. So the drug literally can't turn on inside the muscle.
Exactly. It aggressively targets cholesterol in the liver, but is chemically inert in the muscles. Zero risk of true pharmacological muscle pain.
That is brilliant design. And speaking of brilliant, we have to mention inclisiran. This is an RNA therapy, right?
Small interfering RNA, or siRNA.
How does that differ from the PCSK9 antibodies we talked about earlier?
The antibodies sweep up the PCSK9 protein after it's in the blood. Inclisiran goes inside the liver cell and literally chops up the messenger RNA blueprint used to make the protein in the first place.
Wait, so it literally destroys the blueprint?
It just stops the factory from making it entirely.
Yeah.
And because of how it works inside the cell, a single injection lasts for 6 whole months.
That is wild. Science fiction level stuff. Okay, let's move into the final major section. Special populations, because these guidelines are definitely not one size fits all.
Not at all. They carve out hyper-specific rules.
Let's start with severe hypercholesterolemia, also known as FH. If someone's baseline LDL is over a 190, the source says you don't even bother with a risk calculator.
You don't. Because their lifetime risk is basically guaranteed. They've been exposed to toxic levels of cholesterol since birth.
So you bypass the CPR framework completely?
Go straight to high-intensity statins. And for the really rare, severe type homozygous FH, where levels can be 500 or 600, we use highly specialized drugs like lomidopide or evolocumab.
They don't mess around with an LDL over 190. What about diabetes?
If you are between 40 and 75 and you have diabetes, you are automatically put on at least a moderate intensity statin, period.
Even if your LDL looks normal?
Yes. Because chronic high blood sugar fundamentally degrades the lining of your blood vessels. It makes your LDL particles smaller and more dangerous. We treat the vascular disease proactively.
That systemic approach also applies to chronic inflammatory diseases, right? Like lupus, rheumatoid arthritis, psoriasis. So what does this all mean for those patients?
It means we recognize that the same hyperactive immune system destroying their joints or skin is also causing chronic inflammation inside their arteries.
Systemic inflammation drives heart disease.
Exactly. It destabilizes plaques and makes them much more likely to rupture. Standard calculators actually underestimate the risk for these patients. They need specialized monitoring and aggressive treatment.
Okay, the last special population is pregnancy. And this is a massive shift. Statins used to be strictly forbidden, right? Like category X, do not touch.
They were. The fear was that a fetus needs a ton of cholesterol to develop properly, so blocking it would cause severe birth defects.
But the guidelines changed that.
Yes, because modern data shows the actual risk of birth defects from statins is remarkably low. But the risk of leaving a woman with severe hypercholesterolemia untreated during the extreme stress of pregnancy is actually very high.
So it's about weighing the risks.
Right. The FDA and the 2026 guidelines say it's an individualized decision now. You balance the needs of the mother against the theoretical risk to the fetus.
Wow, that is a huge update. Well, we have covered a massive amount of ground today.
It's a heavy document.
It really is. To summarize, the 2026 guidelines are all about early detection and lifetime exposure. We're using precise new math, like the PREVENT equations, tracking ApoB, using CAC scans as definitive tiebreakers.
And optimizing lifestyle before relying on unregulated supplements.
Exactly. Plus, an incredible new array of targeted therapies like bempedoic acid and RNA inhibitors. But before we sign off, there's one thing in the text that points to the future.
The polygenic risk scores.
Yes. Leave the listener with a final thought on that. What does the future of cardiology look like?
Well, the guidelines talk about dynamic models, like the Million Marts model. Imagine a future where your doctor doesn't use a generic calculator at all. Instead, they sequence your entire genome to generate a polygenic risk score.
So they know your exact genetic destiny from birth.
Exactly. And that algorithm dynamically adjusts in real time as you age, updating with every new blood pressure reading or lab test. We are moving toward predicting and treating your exact biological trajectory before the disease even has a chance to form.
Now, that is an incredible thought to end on. Thank you for watching The Funnel Effect.